Thanks very much. I'm really delighted to be here. Thanks, Grant and the OMF for organizing this event, and thanks, Dr. Singh and team for hosting. It's an excellent location. You might hear a slight accent. People always ask me, where's this accent coming from? Well, I live in Seattle. Well, actually not born in Seattle. Where I came from is in Austria. I moved to Seattle 18 years ago for my postdoctoral research. I worked at the University of Washington. Interestingly, I started at the Department of Ophthalmology at the University of Washington and worked there for 2 years on signal transduction in the eye. I cut a lot of bovine eyes in order to get all the material, but then switched very quickly to molecular biology, did a second fellowship in cancer research and immunotherapy. And the reason why I moved to Seattle, because equally nice is Washington State, as you can see. And that was one of the major reasons. I was driven by the mountains, and the science is great there as well. So it could not have been shown better than what Dr. Youngen, I think the first name was, in the previous session, when he showed this mountain of the basic science and the mountain of the clinical science and the big skull in between. They're not talking. And this was one of the reasons why I decided to leave academia on one side. I was in basic research, doing lab research for many years, and then I was in corporate and did clinical research for many years. And I saw there's so much knowledge and there's so many regulations, and there's the patient. And I wanted to be much more linking between those two areas. And that's why I started Cancer Treatment Navigator, working directly with cancer patients and applying the science and working with their physicians. So what do I want to do today? Short agenda. I give you a little refresher, and Dr. McNamara already had some homegrown cartoons. I can put his cartoons to shame. Just wait and see my cartoons. They're much simpler and much easier. And then we look into the 3 cancer treatment paradigms that I really think are applicable, especially to Uval melanoma. Targeted therapy, we already talked about it, immunotherapy, and epigenetic modifications. We didn't talk a lot about this yet. And those 3 are, in my mind, the most promising areas right now that we're pursuing in clinical and experimental therapies, because we don't have a lot of options yet if metastases develop, as we already heard this morning. And then last but not least, a few slides of what is the current clinical trial landscape for those 3 options and beyond looking like. But let's start with you can lean back and refresh. It's basically high school knowledge. Little refresher, what is this? So here's my simple cartoon. I think it's, yeah, you're right, I heard it already. It's the cell, it's the building block of every living organism. Just to be fair, I showed what a cell much more looks like. I copied one of those cartoons from somewhere else on the right-hand side. But for the purpose of what I want to do with you, to really focus on the essentials, how is it linked to uval melanoma, I always revert back to the left cartoon, which is the simpler one. Cells come in many different shapes and forms, and if 2 of those cells can meet, and we all know basic biology and the bee and the flower, they form in love, and the cells meet and divide and form and grow. And if everything goes right, then we have a wonderful result. But in nature, things don't go right all the time. A cell division also can go awry. It can go wrong, and then a result can be this. And this is really a tumor. It's not a uval melanoma, fortunately, but it's a lipoma, actually. That is one of the largest tumors ever removed. And this is when a cell division gets out of the norm, with all what we heard already this morning. Now, what is the big difference between the normal cell and the cancer cell? And I don't want to repeat too much what was already said wonderfully this morning, but I want to show in very simple cartoons of what is the main difference as it applies also to ocular melanoma. What is going on first in the eye, and if it becomes metastatic, why is this happening? Now, a normal cell, as we heard, does divide as well, and it should. Otherwise, we wouldn't grow, right? And our bone marrow wouldn't regenerate, and our skin wouldn't regenerate, and our hair wouldn't grow. But it's a different story. But what is the difference between the cancer cell? And in order to understand this, let's look at the signal transduction. And I made it very simple here. The way how a cell speaks to the environment is through receptors. And there's growth factors. At the very top of this cartoon, you see this little white dot. It's a growth factor. Let's just call it growth factors. There's hundreds of them. And there's a cell receptor, and there's a signal molecule 1, signal molecule 2, signal molecule 3. There's the cell nucleus. And how does this work? That the order is given to the cell to divide and to grow. The way is the growth factor meets the receptor. The receptor is a very complex way how this all works, but very simplified. It's electrochemical signals that are transduced from one molecule to the next into the cell nucleus. The cell machinery is started in the nucleus. The cell division happens. The growth of the cell happens. That's fairly well understood. Of course, it's much more difficult than shown in this cartoon, but we only need to focus on this simple principle right now. Now, in a cancer cell, it's a very similar machinery. But what you see here, in a cancer cell, we can have one of those signal molecules mutated. And what is now different than in the normal cell, where we have a signal transduction cascade going on that is dependent on the external growth factor, in a cancer cell, what can happen is that we don't need any growth factor any longer. The mutated molecule can fire the signal off constantly and reproduce constantly. So that's a hallmark in our understanding right now when we say a genetic mutation. When we look for genetic mutation, that's exactly what we are looking for those mutated signal molecules. Of course, this is only one mechanism. We also know, for example, in breast cancer also can grow when we have an abundance of, for example, estrogen. Estrogen, many breast cancers are hormone receptor positive, and if there's too much estrogen, then the cancer can grow. So it can happen this way as well, and that's why we give, for example, tamoxifen. We block simply the receptor, and the cancer cannot grow. Not applicable in this case for uval melanoma. Now let's look into uval melanoma more in detail, and in order to do that, let's compare it to skin melanoma. In skin melanoma, we found quite a variety of mutations. And why do this mutation happen? We already heard during the lunch meeting with Castle Bioscience, we heard in the excellent presentation about genetic counseling that we can have germline mutations and somatic mutations. Now, those, what you see in this cartoon, are somatic mutations. Those are mutations that happen throughout our lifetimes, that are happening actually as we are sitting here, through radiation, through mistakes in DNA copying. So right as I'm standing here, my cells are dividing, DNA has to be copied. There can be mistakes, but we have machineries that repair those mistakes. Viruses and infection, carcinogens, all of those can cause those mutations. And at the end, we find out through sophisticated techniques to find those mutated cells. Genes that lead to mutated proteins that basically have a mutated cancer cell. And the goal of precision medicine is now to have for each and every of those mutations, I mean, that the optimal, the perfect goal, a medication. If we have this mutation in this color, we have a mutation here. If we have a mutation in that color, we have a individual cancer medication here. And the third mutation somewhere else in the whole genome, we have yet another a therapy that targets the specific genetic mutation. And that's the big difference from chemotherapy. Chemotherapy divides every dividing cell, including healthy dividing cells. That's why we have more side effects. With targeted therapy that actually follows these principles, we can hopefully minimize the side effects and maximize the efficacy. Now, in skin melanoma, and now I'm getting closer to melanoma, but we're in skin melanoma. We are not in uval melanoma yet. We have a very good example. We have one of those mutations identified as the Brav mutation. It's a very specific mutation where we know this mutation is very hyperactivating. In skin melanoma, Brav fires constantly a signal that leads the cell to divide and form a tumor. And what did we do in terms of precision medicine? We developed quite a lot of good medications. And in fact, there's 3 on the market right now. The latest one, dabrafenib, that was approved for this metastatic skin melanoma. It targets specifically this specific, and I don't want to go into detail, BRAF mutation, and it can stop the molecule from firing constantly. We have also vemurafenib, and we have sorafenib. So those are all the RAF-inib. Inib is the way how the medication works. And there's the word RAF in there for BRAF. So there is a meaning why molecules and therapeutic agents are called a certain way, because it's related to the molecule, what they're doing. So anyway, we have 3 medications, and it works fairly well. It's also given sometimes in combination. And the tumors can shrink. They can shrink quite dramatically. We have observed this in skin melanoma. Now, do we have this option in uval melanoma? Unfortunately, I'm not aware of any uval melanoma with a BRAF mutation. What is very common in uval melanoma is a mutation that is somewhere else in this signal transduction. And what you have heard, the GNAQ and the GNA11 mutation is very common. Up to 90% in class 2 tumors have this mutation. And this molecule starts to fire on its own without any growth factors, and provides the machinery to lead to the formation of an ocular melanoma tumor, and worst case scenario, later in life metastases. Now, do we have something like that, dabrafenib, like in skin cancer for this mutation? Unfortunately, we don't. We have big question marks here. Those are the bad news. The good news is there's a lot of research going on to find something similar. University of North Carolina laboratory is one of the leading laboratories right now, Dr. John Sondek, who is working with industry to screen thousands of molecules to find a molecule that fits into this mutated form of this GNAQ mutation or the GNA11. They are interchangeable because they have similar or identical functions. So there's a big question on how can we stop this? Now, what do we do in the meantime? And now I go really into the detail of why we run clinical trials in ocular melanoma. In the meantime, we try to find something. Can we do something below? What if we look something at those pathways? And if you look into detail, this GNAQ mutation fires into different directions. It's not that simple that there's only one linear way that the signal leads to tumor growth. There's actually 2 parallel signals, equally strong, and there's 2 molecules actually that we currently use in clinical trials. One is a protein kinase C inhibitor. It's AEB071. It targets it downstream because it's downstream of the mutation. And the other one is a PI3K inhibitor. And that's the principle of how we think about how can we stop the tumor. This is a very early clinical trial. It's ongoing. We don't have results yet, so we don't know if it works as well as the dabrafenib. But it's at least a very reasonable trial to stop the growth of ocular melanoma in the targeted medicine arena. Now, unfortunately, look at this. This is what I show. Those are my homegrown cartoons. Here's a copied cartoon. If it doesn't work, then one of the reasons is probably because it looks more like this. This is a much more realistic picture of the different cell pathways. And if you think this is complex, look at this. Now, this is an understanding of our current knowledge of the integrated pathways in breast cancer. And it looks similar in ocular melanoma. I almost guarantee you that we will find out. And this is the problem. This is the problem we face because the heterogeneity of tumor is another problem. If we eliminate one clone that is due to one mutation, we might find another pathway that somewhere in there gets hyperactivated and the tumor starts regrowing again. So that's where we are struggling in the scientific arena and how to target it all. Now, I quiz you on this afterwards at dinner. You only get dinner if you know one of those pathways in there. So, but how do we even start when we see something like this? And, you know, just take the first step. We have to start with the first step, and we're taking many first steps. Fortunately, those first steps are happening. And one of those first steps are the next generation sequencing methodologies that are coming, that are here. More and more companies are offering those. And those are quite comprehensive tests that look at hundreds of genes that could be mutated and that give us an idea in which direction to go. Now, sometimes I get many questions about the genetic testing. Please keep in mind, and this is very important to mention here, that genetic testing is not equal genetic testing. There is one group of genetic testing, and we heard a lot today already about, that is very important for diagnostic and prognostic purposes. And it allows us to really look at the sort of surveillance or adjuvant therapies if there's a higher risk group. But there's genetic testing, and the objective of the other genetic testing is solely for the purpose to help inform treatment decision based on what I just showed you in those different schematics with the cell signal transduction molecules. So that was the first primer about targeted therapy. Now immunotherapy, we heard something about immunotherapy already, and it's a fascinating field that is rapidly advancing. It works really well in skin melanoma. In fact, skin melanoma is one of what we call the most immunogenic tumors out there. And that's why most of the clinical trials and most of the products that are available in the immunotherapy arena are approved in skin melanoma. And what happens actually if a melanoma metastasizes and forms tumors somewhere in the body, we find that immune cells are usually always present around the tumor. It's very uncommon to not find any T cells. T cells are the soldier cells in the immune systems. They destroy the tumor. However, why don't they work sometimes? And that's the big question mark where we find more and more answers and why more and more therapies that help overcome this hurdle approved. But before going into this, let's go into a little bit more primer of immunotherapy one-on-one, how it works. And all you need to focus on are those few cell types. There's many more cell types, but in general, we have the dendritic cell. The dendritic cell has those tentacles. It looks like a little octopus in order to have more cell surface. And that's important because the dendritic cells is one of the antigen presenting cells, but first the antigen finding cell. An antigen is nothing more than an invader, something that is strange to the body. It can be a bacterium, can be a virus, can be food that we eat. It can be a cancer cell. A cancer cell is usually recognized as strange. And the antigen recognizing cell, equally antigen presenting cell, finds those cells first, those molecules on the cells. This other cell type are the T cells. First it's a naive T cell and becomes a mature T cell. So those are the three players in the immune system, and here's the player on the cancer side. It's the cancer cell that forms a tumor, many cancer cells. And the goal is of the immunotherapy, as any other therapy, is destroyed tumor. Destroyed tumor is still something, and this something is also important because this something must be cleared out of the body, and how this works is usually the immune system as well, which has important implications. So if you put those cells all together in a diagram on how this all works, it looks more like this. It all starts with the cancer cell, and the cancer cell has a molecule on the surface. We call it antigen. Again, antigen is synonymous for stranger, something that is strange, something that is not known to the body. The dendritic cell is made to recognize those, and then it's a complicated process. The dendritic cell matures and presents this antigen to a naive T cell. In this process, the naive T cells get educated and becomes a mature T cell. And the mature T cell now is able to recognize this stranger molecule on the cancer cell. They connect with each other, and the cancer cell can get destroyed. So that's what I call the immune cascade. That's the simplified process of what's going on. The problem we face, that once we have a big tumor, the tumor produces lots of substances and lots of obstacles for this to happen. And we have lots of barriers. And I call those barriers 1, 2, 3, 4, 5, 6 to make it very simple. And the first barrier is we have an impaired production of cancer-specific antigen. And this is the most important that I want you to remember for Uval melanoma, because I get back to that. This very first step here, an antigen. Uval melanoma cells, especially class 2 cells, look very simple. They don't have a lot of antigens on the surface. That's a huge problem, and this is one of the reasons why it appears that uval melanoma is not as targetable with the immunotherapies that work really well with skin melanoma, because skin melanoma has many more antigens. But a little bit more about this when I talk about the epigenetic modifications. So impaired production, if the dendritic cell cannot see the cancer cell, we have a problem. And the tumor itself can do this through certain mutations. The second, the dendritic cells cannot mature. The third, the antigen presentation to naive T cells can be impaired. The fourth obstacle is the naive T cells cannot mature and become a mature T cell. And the big obstacle here is that the mature T cells can see the cancer cell, but it cannot work to destroy the cancer cell. Now, and the last impaired cancer cell signaling for self-destruction. Now, in our research on how to overcome all these hurdles, we have made big progresses. Here, for example, we can interfere with epigenetic therapy. We also call it immunogenic priming. Here, we can interfere with cancer vaccines. And everything that is further up is further upstream in the immune cascade. In this area, we heard most of the comments and presentation already this morning. The immune checkpoint inhibitors, ipilimumab, nivolumab, pembrolizumab, and many more that are coming down the pike. They work that the mature T cells that sees the cancer cell but cannot act on it overcomes this hurdle. That's where those checkpoint inhibitors come through. And the T cell therapies in itself, we have tumor-infiltrating lymphocytes that we target towards melanoma, or we have T cells that we generate completely artificially, so-called chimeric antigen receptor, CAR T cells. So those are all areas, and the reason why I'm telling you, because those are currently everywhere clinical trials in uval melanoma in those areas. Now, remember, number one, the problem that the uval melanoma cell cannot be seen really well. That is a big problem, and you can, so to speak, in easy language, dump as many nivolumabs, ipilimumabs, and pembrolizumabs onto a uval melanoma cell if the T cell cannot even see the cancer cell. You can hyperactivate T cells as much as you want. If the T cell cannot find the uval melanoma cell, we have a problem. And this could be one of the reasons why we don't see as good of an efficacy with the immune checkpoint inhibitors as we see with skin melanoma. Now, let me go to the third primer that I want to give you about the three big areas of therapies currently in development and in clinical testing for uval melanoma and other cancers, of course. It's the vast area, scientific area of epigenetic modification. And in essence, what it is, it would be too easy to just have a chromosome or to just have a gene or so. A gene is nothing more than a recipe. It was nicely presented. And there's thousands of recipes, in fact, up to 25,000 genes that we know are sitting nicely and tightly packed in a library. If no one can go in there and take out a book and read the recipe, nothing happens to it. And that's when the DNA is hard to read. It's nicely packed around a packaging system. We have to unfold the packaging system that we can access a gene on the DNA, similar to going into a library, pulling out a book, reading the book in order to bake the cake, or in order to read the gene, or in order to produce something out of the gene. Now, why is it applicable? And what is the difference, again, between skin melanoma cell and ocular melanoma cell? A skin melanoma cell, as I mentioned previously, is one of the most immunogenic tumor cells that we know. Most of the immunotherapies were first discovered in melanoma cells. Skin melanoma, in fact, if we could make it visible in a way, looks much more colorful than does ocular melanoma, especially in the class 2 arena. And that's believed to be one of the major hallmarks. Whoever had a chance to listen to Dr. Harbert's talk on the Ocular Melanoma Forum about a month ago, it was a webinar. It was a very fascinating talk, and that's where his leading research is. Why does this happen? Because of the Bab1 mutation. So what can we do to change this, that the ocular melanoma cell becomes more immunogenic, that it becomes more colorful? More colorful means, hey, I'm here, get me. and the T cell can go after it. It's not happening as easily with ocular melanoma cells. So this is, again, if you go back to those many different colors on the cell is basically the same as I showed here, the antigen, the very beginning of the immune cascade. So we need to have all those molecules present that the whole immune cascade starts even working. Now, the skin melanoma cell has a lot of infiltrating lymphocytes, tumor infiltrating lymphocytes. And I highlighted this here. If you surgically remove portion of a skin melanoma metastasis, you usually find a lot of tumor infiltrating lymphocytes because the skin melanoma is usually very colorful and there's a lot of different immune responses launched against the skin melanoma cell. And that's why immunotherapy works well, because we can beef up those T cells. We can give additional substances to overcome all the hurdles that the tumor produces against the immune system and can make them work again. And it usually works really well. With ocular melanoma, there's only a few sticking around because it's just not as colorful. And the big difference here is the Bab1 mutation. Again, DNA is packaged in all those different proteins and molecules, and it's very tightly packaged. And it's so complex, so this is copied cartoons that I took out, that the way how DNA is packaged is through chemical reactions. There's many chemical reactions. And what is most important are two, the acetylation and the ubiquitination. Sounds very complex and complicated. It's not as complex. What it is, we know that the Bab1 mutation interferes with this so-called ubiquitin. Ubiquitin is a residue on those packaging molecules. And this residue comes with a electrical charge, a negative or a positive charge. Now, Bab1, if it works normally, reduces ubiquitin and the charge changes that allows the DNA to unfold from the packaging material, and we can read the genes, and we can produce a lot of those colorful molecules on the cell. If Bab1 is mutated, this whole reaction doesn't work. The DNA cannot be unpacked, and all those colorful molecules cannot be produced. We call this this mutation that this Uval melanoma cell looks much more undifferentiated. It looks much more like a primitive stem cell. And that's what the Bab1 mutation does, because that's the belief of how this process works. Now, can we overcome this? Not directly. We don't have anything that interferes with the Bab1 mutation, but there's so many other chemical reactions around this packaging material for the DNA that we can change another residue, and we do this through a so-called Htac inhibitor. An Htac inhibitor is a histone deacetylase inhibitor. An acetyl residue is a residue that gives the protein or the packaging material another charge. And if we give an Htac inhibitor, and varinostat or valproic acid are known Htac inhibitors, we change the electric charge of the packaging material that was changed by the Bab1 mutation, and we change it back to something that DNA can be read again. This way, the whole machinery to produce all those colorful molecules restarts, and the Uval melanoma cell can get much more colorful. That means it can trigger a stronger immune response. And that's the lead research in this area is Dr. Harmut and his laboratory down in Florida. Really fascinating work. But this is about as simple as it gets, terminology of how it works. So again, Bab1 mutation and no Htac inhibitor, the DNA is very hard to read. If you have a Bab1 mutation and give an Htac inhibitor, the DNA gets really easy to read. And in simple terms, this is how it looks like. Here, a Uval melanoma cell, hardly any molecules on the surface because of the Bab1 mutation and no Htac inhibitor. We believe if we give an Htac inhibitor, we make the Uval melanoma cell look much more like this. And that's the hallmark to make immunotherapy a much better option for Uval melanoma. And there's a lot of research in this area going on. Because this is the first important step so that all the other immunotherapies that work well already in skin melanoma potentially work well in Uval melanoma as well. Okay, so you're probably close to brain dead after all those scientific explanations. Let's go into something that is really tangible. It's the clinical trial search. Now, how can those different areas fit into what we have for uveal melanoma currently in the adjuvant setting as well as in the metastatic setting? Again, adjuvant setting is the setting right after the primary first line of treatment, which is usually surgical or radiation treatment. And it serves the prevention of the formation of visible metastases. So even if there's micrometastasis present, we give something to prevent metastases to form, usually in the liver. And then metastatic ocular melanoma treatment is when we have already identified metastases. And this is roughly how the landscape currently looks like of really something that is noteworthy. Unfortunately, it's not a lot of trials all in all. If you go into skin melanoma, it's 10 times as many. And the reason why, because unfortunately skin melanoma is so common and there's a lot of money behind and there's a lot of power behind, and that's why the ocular melanoma forum, each and every one of one sitting here, is very important to voice that a rare cancer, because this, I explain very often in my job to many people that the sum of all rare cancer is more common than the most common cancer. And that's something that is especially important in immunotherapy as well as in targeted therapy, because we don't care any longer where the cancer originates. We care what the reason for the cancer is and how can we target this reason and not where it is. And ocular melanoma is one of those diseases. How did I get to those numbers? By simple, the easiest and best known database is clinicaltrials.gov, and I'm sure that many of you have been on this website. If you search, and that's where the whole troubles with trial search start. If you type in ocular melanoma, click enter, you get 78 studies. If you type in uval melanoma and enter, you get 34 studies. So go figure. What I want to show with this one, it's not an optimal database. Nothing in nature is optimal, and nothing in what we make as humans about nature is optimal, because someone has to type in the clinical trials into this database, and someone has to type in the keywords so that we find clinical trials. And each and every one types it in differently. I see a lot of things. I search hundreds of thousands of clinical trials. I go to different databases. I have a lot of connections, and I know what is coming, and I know that sometimes a clinical trial is open and is running and is not even listed here yet, or a clinical trial is listed as recruiting and had closed 10 years ago. So you find it all on a database because it's just how it's not streamlined on how we are entering it. So now, 78, that's what I prepared for today, and I looked at those 78. About 30 to 40 are not applicable to us. Those are skin melanoma trials that exclude. They even mentioned that they exclude ocular melanoma. Now, why are they listed, Venna? Because they're excluded in ocular melanoma, so the search machine finds them as an ocular melanoma trial. So you exclude those 30 to 40, then you're left with about 40 trials. And some of them are not applicable because they are only laboratory studies, or there are very important studies also listed because radiation after first-line treatment in the eye can cause inflammation. There can be side effects. So there's good clinical trials to look into those areas. The ophthalmologists in the room can tell us much more than I as a scientist can tell you about those trials. But those trials I did not include. In a nutshell, we end up with those few trials that are currently available for searching for ocular melanoma. However, there might be more trials that will include in targeted therapy and precision therapy, as we find more mutations, might make it possible to include ocular melanoma, even if it's not listed. There's many trials that list the participation of any solid tumor that has this certain mutation or this certain behavior pattern or this certain pathology or treatment pattern. So there's a lot of what I call the all-comer trials for all solid tumors, which might include ocular melanoma as well. Now, going quickly through the targeted therapy, the first area, and some of those trials were already listed. In the adjuvant setting, we have currently crizotinib post-surgery plus minus radiation therapy. That's an interesting trial. Crizotinib is approved for lung cancer, for a certain mutated form of lung cancer in the ALK mutation. But crizotinib is a molecule that also targets a molecule called c-Met. Despite the fact that most ocular melanomas are not mutated in c-Met, I'm not really aware of any mutations. However, it plays an important role of the motility of the cancer cell, and it's believed if we limit the motility by interfering with crizotinib, then we limit the ability to freely swim around as micrometastases and find the liver. So that's one of the. And then there's a Sunitnip trial. The trial currently is Sunitnip or valproic acid, so it will also be listed at the targeted the epigenetic modification trials. Now, Sunitnip targets at least 7 molecular targets. I still have problems with some of the so-called targeted medicine to call them targeted medicines because we have a lot of those IPs at the end, Sunitinib, Sorafenib, Cabozantinib, those are all the tyrosine kinase inhibitors, and some of them cover up to 10, 12, 15 different targets. Those are, in my mind, not really targeted molecules. We see the more targets they target, the higher the side effect profile. And with Sunitnip, I'm not really sure what the target in ocular melanoma is. I'm not scientifically bought on the idea why Sunitnip should be a good trial in the either metastatic or in the adjuvant setting, but maybe someone can convince me otherwise. Then in the metastatic ocular melanoma trials with targeted therapies. Remember the one trial that I showed where the GNAQ mutation, the cartoon, where the 2 parallel pathways go? The first trial is a very interesting trial. It targets indirectly this mutation, GNAQ and GNA11, by inhibiting the downstream targets. Then we have another c-Met molecule, investigational experimental medicine, currently in clinical trial. It's a complicated number and letter name, but it does the same as crizotinib does and inhibits motility of ocular melanoma cells, and that's offered in the metastatic setting. Sunitnip is also in the metastatic setting. Cabozantinib also targets at least 10 molecular targets, is in the metastatic setting. And one molecule that seems to be interesting and somewhat targeted, not necessarily to signal transduction molecules. This trial is offered in the UK currently only, but there is a similar trial in combination with a vaccine in the US. What this molecule does, it breaks down the amino acid arginine, which is required for ocular melanoma cell survival. It's more required for survival than for normal body cells. Then the immunotherapies. As you see in the adjuvant setting, we don't have a lot, unfortunately. There is hardly any adjuvant trials because it's difficult to recruit trials that might run for 5 years because it's a fairly rare disease. And companies are not as interested in running adjuvant trials. But nevertheless, we have pembrolizumab, as you see, abbreviated to Pembro, for stage 3, end stage for ocular melanoma. So the stage 3 is more the non-metastatic setting. And then we have RNA pulsed dendritic cell vaccine, which currently is offered in Germany only as well, in the adjuvant setting. And then in the metastatic ocular melanoma trials, we have vaccine settings with this FLT3 ligand that makes the dendritic cells stronger. Then we have an antibody that is linked to a drug. And this antibody finds a molecule that is usually present on ocular melanoma cells and delivers this drug only to the ocular melanoma cell. This trial just opened, so it's fairly new. So it's a targeted sort of immunotherapy trial. Then we have the immune checkpoint inhibitor pembrolizumab or ipilimumab, nivolumab combination. This is a fairly new trial that is offered for solid tumors. It was offered to, I know, 1 ocular melanoma patient at MD Anderson, although it does not specifically mention ocular melanoma being in the inclusion criteria. This is a combination trial of ipilimumab or pembrolizumab with an antibody that has an undisclosed target. We don't know what the target is because the company didn't even list it in clinicaltrials.gov, and nor the company website says what the target is. And this trial just was opened mid-October, just a few days ago. It's a very interesting fusion protein, IMC-GP100. It's a fusion protein that targets that the T cell can link better to the cancer cell, to the ocular melanoma cancer cell, so they can do a better job, and very, very promising technology. Then tumor infiltrating lymphocytes, there's a few trials open, mostly at the NCI. Again, it requires usually to remove some of the liver metastases surgically and take out the tumor infiltrating lymphocytes. And then the CAR T-cell trial targeting certain molecules that we hope are on the surface of ocular melanoma cells. But again, the caveat with all of those ocular melanoma trials in immunotherapy is the ocular melanoma cell, especially the class 2 cell that is the most risky, colorful enough that all those technologies even work by seeing the immune system. And that brings me back to the last big category that I focused today, the epigenetic modification trials. Remember the Bab1 mutation that makes the Uval melanoma cell look so simple, so gray, not colorful, and the immune system cannot see those cells. Valproic acid, there's a little typo in here, but with all the ipilimumabs, this can happen, is currently in the adjuvant setting. And vorinostat, as an Htac inhibitor, is in the metastatic setting. Now, both of those agents are commercially available. They're approved for other indications. You can flip-flop those, and you can actually get them off-label as well as for the vorinostat for the adjuvant setting. And just for completion, there is, of course, combination trials that combine inhibitors, targeted inhibitors, with vaccine combinations. And that's an interesting trial in the adjuvant setting, and one of the most interesting trial, I think, right now in the adjuvant setting. And in the metastatic setting, we have the same combination in the adjuvant setting. Then we have a lot of combination trials. We have a so-called targeted therapy with the 7 targets. It's raffinib targets, and radioembolization is a combination trial. We have tumor-infiltrated lymphocyte therapy in combination with a targeted medication, a so-called Htac inhibitor. We have a certain form of paclitaxel plus bevacizumab or irinotecan. So we do a somewhat targeted trial with old-fashioned chemotherapy. And then we have this trial that I mentioned is offered in Germany as monotherapy only, but we have a combination trial of this ADABAC20 with chemotherapy, in fact, cisplatin, that is offered in the United States. And chemoradiation, we have prophylactic hepatic irradiation as an open trial in the United States to prevent the formation of metastases. And then we have a few combination trials in the metastatic setting with chemo and radiation that are interesting. So that was the whirlwind tour through cancer treatment navigation based on scientific facts and targeted to Uval melanoma. That's what I'm doing for a living. I'm working with a lot of patients. I've worked with currently 4 Uval melanoma patients. It's very interesting to compare what's going on. My observation was, and my big requests to the oncology community, I see, unfortunately, sometimes, especially more in the community setting, when an ocular melanoma patient, a metastatic patient, ends up with an oncology center, and they hear the word melanoma and treat as if it's a metastatic skin melanoma. I think that's wrong. It causes too many side effects. If you give immunotherapy combinations, they don't get us anywhere. I saw 2 bad outcomes, unfortunately, with the attempt. We have to look deeper into science with ocular melanoma because we are not there yet where we are with skin melanoma, and that's very important. Please let anyone know if you go to an oncology center, don't let it treat as skin melanoma. It's a different disease. Ocular melanoma is a different disease, and that's very important. With that, if there's any questions, please feel free.
First part of my question is, since valproic acid is old and cheap, can it be substituted in theory for the vorinostat?
In theory, yes, because it's known. I mean, the indication for valproic acid is a different one. So if you get too much, then you're very sedated, and that's the initial indication. Unfortunately, in all those off-label scenarios where we don't have well-controlled studies, we don't even know what the right dose is. So that's where it starts. We don't have data from clinical trials yet. The science is supportive. The clinical data are not supportive because we just don't have them. So the question, does it have the same acetylation capacity, valproic acid, that is required to change the charge to make the tumor cell more colorful as vorinostat? I don't know. There's ways to look into that. I'm not aware that someone ever looked into it because it was never used as an Htac inhibitor. So that's, I don't know if this answers your question. Yes. We don't have data to support that I just can switch those two, and the pill looks the same size. Maybe I take the same size pill and it does it.
But either way, you have to have a Bab1 mutation to make either of those relevant, and if you don't have that, it wouldn't necessarily be relevant?
That's the current theory behind, yeah, and the hypothesis.
If the only testing you've had is Castle testing and you're Castle 2, what of the data that you presented today, what do you feel most positive about?
Yeah, so you remember back this one schematics where I say I quiz you, where there's so many pathways, hundreds of pathways, so there's hundreds of genes involved. The most comprehensive test currently that is on the market is called Foundation-1 from Foundation Medicine. It's a next generation sequencing test offered by a company that's out of Harvard. They are in Boston, and they look at a total of up to 400, close to 400 genes if they're involved in ocular melanoma, and if they are, they will very likely find it because they look at the entirety of the genes. There's similar tests out there. There's other hotspot channel tests out there. There's a newest test out there with a company called Guardant Health. Guardant Health also does next generation sequencing. It looks only at 68 genes, but the big news with this company is they work with liquid biopsy. So you don't need a tissue any longer. You can use 2 vials of blood. It sounds great, and it's the right approach, and I hope that we all switch to this approach because it's based on the theory that every tumor sheds DNA into the bloodstream, and we can find this circulating free DNA, cfDNA, in the blood. However, this test is not validated enough in my mind. I didn't see any studies. I know Foundation Medicine and the University of Washington Oncoplex test and Knight's Diagnostic Lab and all the different labs, they have validation studies that have been published in peer-reviewed journals. I don't know of any test with Guardant Health, so I would be very careful because we don't know if there's a correlation between the amount of free DNA and the amount of tumor. So if we don't have measurable tumor, if we don't find anything, that doesn't mean there isn't anything. That's what I want to say. So we can have a risk of false negatives with this test because it needs to be better validated. It's offered already. It works probably well in tumors with a high tumor burden, a high metastatic burden in breast cancer, lung cancer, colon cancer, where you can see readouts very similar as you see with Foundation Medicine. With the difference, it looks only at 68 genes. But I'm not so sure if it works really well in a disease where we don't have measurable disease.
Are they related to the outcome?
Well, for example, the GNA mutation, GNAQ or GNA11 mutation was found in a few of the patients I worked with through Foundation-1, and the goal is to end up in one of those trials that is downstream of GNAQ. A PAP mutation was found in Foundation-1, and the patient is on vorinostat.
The question of circulating tumor DNA, free DNA, whether the reference of that related to the outcome of cancer. Say colon cancer patient. You found circulating tumor DNA in the blood. Does that reflect prognosis or there's no correlation?
I'm not aware of any correlation yet. I think it's similar. There's two big areas of research, circulating tumor cells as well as circulating free DNA. Both are, in my mind, in its infancy. We have one test for circulating tumor cells. We look at outcome data, if they're there. The question is, are they circulating cells? You find more of them if there's a higher tumor burden, and I think you find more free DNA if there's a higher tumor burden. Are they really the outcome markers, or is it already the disease burden that we have anyway? So they are so close related to each other. I am not aware of any good studies that you have circulating free DNA and no measurable tumor and has been linked to any outcome, overall survival.
So just to put this in the context, excellent presentation. I want to make a comment here. So we normally do eye biopsy to find the tumor cell, right? That's how you figure out the genetics of the tumor. This is an alternative. It may not be equivalent, but it's an alternative, and we don't know whether it's true representation of that. It's not indicating the prognosis, but instead of being biopsy, you may get that information from the blood sample. Whether that matches exactly with the eye sample or not, that's not been done. But that's the area. Somebody has only one eye, for example. Then you say, no, I'm not very keen to do a biopsy because we know there can be hemorrhage and other remote possibility of complications. So this may be a way to get that information, whether you have Htac mutation or whether you have Bab1 mutation. So limited information. So that's a kind of an alternative.
I have ordered this blood test only twice. We found mutations, different cancers. However, I'm a pest to the company because I have so many questions about validation. And I know that they couldn't provide those.
This is an area of research here in our lab, and that's what I was asking.
We have one more question up here.
Hi, Dr. Stecher. Hello? Oh, okay.
Yeah, works.
I want to thank you and everyone associated with this wonderful seminar. I was wondering if you could talk about your thoughts about immunoembolization procedures as a treatment option.
So the question was immunoembolization treatment. So one question back, I assume you mean the combination of some sort of embolization, liver-directed embolization with
Yes.
immunotherapy?
Yes, a liver
Because
directed.
the immune system, there is no immunoembolization as a technique. So we have to combine it. Radioembolization or chemoembolization are techniques in the liver. And to combine it with immunotherapy. A very, very interesting question, very interesting science behind, because what we believe happens in cells like ocular melanoma cells that are not really immunogenic, if we destroy them by other means through embolization, we have a lot of necrotic cells in the liver. A lot of necrosis triggers usually an immune response. A lot of immune response means there's a lot of new antigens in the cells that are not visible to the immune system in other means, and this could trigger an immune response, an internal immune response that if we support it with other immune checkpoint inhibitors might have a better outcome than immune checkpoint inhibitors alone. So yeah, absolutely a very, very important thought that has to be pursued, especially in ocular melanoma further. No. I should, yeah.
Thank you very much.